acute lymphoblastic leukemia, CD20 is expressed in about 30 to 40% of patients. And this expression has been shown to be a poor risk factor in several studies, including one from our group. And one previous study from the MD Anderson in Houston, Texas, has suggested a potential benefit of adding rituximab versus historical controls receiving chemotherapy alone. This is on this basis that we aim to randomize for the first time the use of rituximab in addition to chemotherapy in these patients. We included 220 patients with newly diagnosed and previously untreated Ph-negative BCP-ALL, age 18 to 59, and very standard criteria listed here. And the CD20 positivity was defined as more than 20% of blasts expressing CD20 in the marrow. This is the chemotherapy backbone of the Graall group, of our cooperative group for Ph-negative ALL. And the blue arrows indicate the infusions of rituximab that were performed during induction, consolidation, late intensification, late consolidation blocks, and during the first year of maintenance for 6 infusions, giving a total of 16 infusions and 10 in case of salvage reinduction. Here you can see that both arms of randomization were well balanced for pretreatment characteristics, including age, ECOG status, white blood cells, CNS involvement, and different types of cytogenetic features at diagnosis, as well as for poor early blast clearance either in peripheral blood after the first week of steroids or in marrow after the first week of chemo. So thanks to that, the proportion of high-risk patients defined on this criteria was quite comparable in both arms, corresponding to about 2/3 of the study population. Despite this, allogeneic transplantation that was decided based upon the risk stratification was performed more frequently in the rituximab arm, probably because of donor availability that was different in the two arms. Here you can see the primary endpoint analysis that was event-free survival, and as you can see, patient treated with rituximab has a higher probability of EFS, 65 versus 52% at 2 years, and this difference was statistically significant with a median follow-up of 30 months. And we also performed an analysis why sensoric patients at the time of allotransplantation in first remission, and by doing this, the difference remained significant. In multivariate analysis, treatment with rituximab was still impacting on EFS together with other factors mentioned here, such as age, white blood cells diagnosis, as well as CNS involvement. And notably, when we introduced allogeneic stem cell transplantation in this multivariate analysis, rituximab and all the same factors remain significantly impacting on event-free survival. Thus, in conclusion, in our experience, around 1/3 of patients with BCP-ALL express CD20, and in this patient, the addition of rituximab to standard chemotherapy is well tolerated, significantly improves event-free survival, and also prolongs overall survival for patients who do not receive allotransplant in first TR. We thus believe that this should become a new standard of care for these patients, although some specific points, such as the definition of the best dose schedules, needs to be further studied in future studies. Thank you.